2011, there were more than 400,000 emergency room visits from prescription drug overdoses. These are just ordinary people. These are our brothers, our sisters, our co-workers. These folks have been prescribed opioid medications for legitimate pain reasons. But Dr. Love, we're not here today to talk about these people. We're here to talk about us, about our role as the prescribers. In particular, we want to talk about several specific areas, about our role as the prescriber, about the challenges we face preventing addiction with our prescribing, and about our responsibilities as prescribers. Okay. So what do you think is happening in Dane County that so many people are being prescribed these medications?
I think that you have a lot of very ethical physicians who are addressing their patients' pain needs in a traditional fashion. The patient comes in with a complaint of pain, they do an assessment of that pain, and then it has been customary for decades to look to opioid medications as the primary reliever of severe pain. And so once they've done their initial assessment, they reach for Vicodin or Percocet or morphine to address their patient's pain needs. And they pretty well take the patient at face value because, as you say, these are people that we know, these are people that are contributing to society, so we take their complaints at face value. And that's where I think sometimes the difficulties begin, is we're responding to a complaint of pain, not to an assessment of what that pain is really doing to the patient or how the medication is helping the patient.
So 20 years ago, we weren't prescribing these levels of medications.
No.
Were we treating pain worse then? Are we doing better now? Why has there been such a change, and has that been good?
I think you could say yes and no to everything you just said. I think that 20 years ago we were giving a lot less pain medication, and I think the Joint Commission's addressing pain as a fifth vital sign was an important step forward, because I think it raised physicians' consciousness and nurses' consciousness and society's consciousness to the idea that we should be addressing patients' pain needs. I think the problem that was created was that in addressing the patient's pain needs, we jumped over to addressing the patient's pain complaints. And we did not have assessment tools to kind of cross-check whether the complaint matches the need for pain medicine. And so I think we inadvertently, in good faith, began prescribing ever-rising doses of medication without looking at how effective is that.
In 2011, the Institute of Medicine came out with a report looking at the levels of pain in America, and basically they said that about 100 million people in America still live in chronic pain. And they said that incidence of pain is rising. How can it be if we're prescribing more medications we're having more pain, or why do you think we're having more pain in America?
I think that there are several factors that are in place. I think one, the culture of the role of pain medicine is to eliminate pain. I think that's a very basic fallacy. When you look at pain as a vital sign, pain has survival value. Pain lets us know something is wrong. Pain lets us attend to the affected body part and try to find a way to make it better. And opiates are only a small part of that. They're not the main, they're not the only thing. And I think that shift where opiates has become the main or only thing we use to treat pain has kind of distorted our practices a bit.
Right. I think that's a really good point, that opioids seem to have become our main way that we're treating pain now. What do you think about that? How has that happened that we are using those as the primary pain treatment choice nowadays?
Well, I think the push was somewhat historical in the last 20 years. There's been a lot of pressure to address patients' pain needs, and the tendency has been to do it by patient complaint. And so there's been a tendency to reach for the most powerful thing we have to decrease the patient's complaint of pain. And opiates are the most powerful thing that we have. Unfortunately, as you know, the more powerful the opiate is, only half of the opiate's power is treating physiologic pain. The other half is distracting the patient from the pain with euphoria. And there lies the problem with addiction and tolerance and so on.
Right. Meaning that the people that maybe have more of the mental health effects of it, that more of the euphoria may be more likely to become addicted?
Absolutely. Absolutely. And so we certainly see a lot of patients who've got dual diagnoses. They have issues with depression or anxiety disorders or things like that. Or maybe just a cultural perception of what the doctor's role is in relieving pain, and so their expectations are somewhat unreal.
expanding that thought a little bit as far as how opioids are working, both with the mental health and the physical health effects. There have been some studies showing that people that receive opioids after an injury, in particular after back pain in a workers' comp situation, have delayed recovery times, increased incidence of disability later on, higher medical costs. Do you think that's because of the mental aspect of these medications, or why is it that sometimes people don't get better as fast when they're taking opioids?
I think it's a multifactorial thing that we don't fully understand. I think the mental health aspects are certainly one part of it. I think an over-reliance on pain medication is a huge part of it. One of the things that we try to do in pain medicine is try to have a multifactorial approach to the treatment of pain. We use opiates as the last thing that we add on. We try to emphasize basic things like self-care, lifestyle modifications, simple things like avoiding nicotine, low-impact exercise are very, very powerful things, and patients are frequently surprised that we recommend those things as the foundation of pain care.
Yeah, and I will speak as a family physician who has treated pain for many years. You know I am guilty, and many others are guilty of using the pain pills first, and you mentioned using all these other modalities, but oftentimes in primary care, we don't have the resources, we don't have the expertise, we don't get the reimbursement for that time that it takes to spend with the patient to talk about these other issues. Do you have any suggestions on how we can get past that?
I think a team approach is very important. I found it very beneficial to reach out to physical therapy departments. I found it very beneficial to get social services involved. I get family involved where I can, because we need, in the assessment of pain and the assessment of the pain medication's effectiveness, we need to have eyes on the patient. We cannot rely on the patient's description. I mean, they're controlled substances, so you have to have a second pair of eyes to validate what's happening with the patient. I work with physical therapists heavily because they provide that second set of eyes, and they also let me know if the patient's really actively engaged in self-care, if they're engaged in physical therapy, because if the patient doesn't buy in, if the patient doesn't engage, then you don't get results. And I think that lack of engagement is maybe the underlying thing why sometimes patients don't recover as well and why they over-rely on narcotics from the patient point of view. They're not ready to commit to being a participant in their care.
Right. So how can we get them to commit more? I agree. I think that's a very important part, that people become an active part in their treatment program. But I also agree that I've seen that where people just want me to fix them. They want me to get rid of the pain. How can we engage them more, do you think?
Well, I think we have to, first of all, recognize that while we want to have a good relationship with our patients, we're not there to be their friend, we're there to be their advisor, their expert. And I think the consumerist approach to health care, too often the doctor gets pushed in the role of being a confidant or a buddy rather than being an advisor, more of a parental role. We've gotten away from that somewhat, but it's still a vital part of that professional distance of being a physician, is to tell the patient what they need to hear, not what they want to hear. And that's sometimes telling them, you need to commit to this, you need to do this, or we're not going to be able to take the next step. Now, in terms of cost-effective care, which is a huge issue for all of healthcare today, insurance companies, government agencies like CMS are starting to recognize that if we don't do the basics, the more advanced stuff doesn't work. So there's now starting to be a requirement that you don't get to have this kind of medication, you don't get to have an injection until we've documented that you have tried so many weeks of physical therapy. So that paradigm is shifting to help us encourage the patients to do the right thing.
You mentioned the challenges that primary care doctors have engaging the patients in their treatment program. What other specific challenges do you think physicians face when it comes to prescribing opioids?
Well, the first thing is, with chronic pain, the pain's been there for at least 3 months, if not 6 months. So the markers that we're taught to evaluate pain or acute pain are gone. There's no increase in blood pressure, there's no increase in heart rate, there's no dilation of the pupils, there's no change in skin tone. So you're having to rely upon the patient's description of their pain and the description of the impact. So without an assessment tools and without validation from other sources to validate what the patient's actually doing, we can't really assess the level of pain nor the effectiveness of therapy.
So in the past 20 years, the number of opioids that have been prescribed has increased by about 600% in our country. And we're seeing, as we mentioned earlier, the increase in overdoses and deaths. There seems to be a balance that needs to be reached as far as the number of opioids that are prescribed and the safety of the public. Where do you think that balance lies?
I think that balance lies in doing the hard work of assessing the patient and changing some of our habits. Now, here in Dane County, there's been some discussion across the healthcare systems about some of our habits as physicians. Again, physicians are well-intentioned. Physicians trust their patients with good reason because, our patients are solid citizens. They pay their taxes, they go to their jobs, they have good families, they have a pain problem we're trying to help them through. And they have busy lives, we have busy offices, so the tendency has gone from prescribing 3 or 5 or 10 pain pills after a surgery to prescribing 30 or 60 after a surgery because we don't want the patient to have to call us all the time, and frankly, we don't want to have to listen to the phone calls all the time, so it is simpler to give a bigger prescription. The problem is many patients, if not most patients, don't even use a quarter of that pain medicine nowadays.
Right. And then it ends up in their medicine cabinet and later becomes a temptation for somebody to borrow, we'll say.
Correct.
Yes.
And that's a significant issue.
Can you give me 3 takeaway points that you think are important that physicians should know regarding this situation?
I think for a physician to effectively deal with pain, and a part of that is to effectively use opiates in the treatment of pain, the first thing is to be sure that you've done a thorough assessment, you've arrived at the correct diagnosis. If you don't have the correct diagnosis, you don't know how much pain to expect the patient to have, you don't have an idea of how long the patient will have the pain or what the recovery pattern will look like. The second thing is, since effective prescription of opiates is dependent upon assessment, you need to have a battery of assessment tools to assess whether it's appropriate to give the patient narcotics in the first place, and then as you treat the patient with narcotics, whether it's appropriate to keep giving them. And lastly, you have to have a care plan that's multimodal. You have to have a care plan that builds like a house of foundation. You have to have a foundation of patient modification of their lifestyle. You have to have a modification of their activity. You have to use conservative care like physical therapy. You have to be open to alternative therapies like water walking, Tai Chi, acupuncture. You have to go up the World Health Organization ladder of pain slowly. You have to use basic things like acetaminophen, use things like ibuprofen, and reach for the narcotics last.
All right, very good. Any other comments before we close?
I think that as awareness of this problem becomes more widely understood, I think that healthcare will do what it's always done, which is make appropriate changes to improve care.
All right, very good. Thank you very much.
You're welcome.